It has a huge impact because the patient with a leadless pacemaker, they usually do not realize that they have a device. In contrast to the other patients with a transvenous system, I think that's the biggest impact on quality of life. The patient population with actually the highest incremental benefit from leadless pacing are the younger patients, because they will suffer over the longer term from all the complications associated with a transvenous device. So the biggest impact would potentially be in the younger population. They should get the leadless pacemaker actually rather than the elderly, because they will have more benefit over the longer term. Leadless pacemaker implants are usually faster and go very smooth with a low risk of complication. That has a huge impact on how we handle patients in the hospital. So we can actually implant more patients per day. The shorter procedure time and the safe procedure intervention makes it very attractive for the hospital. So implanting leadless pacemaker via the jugular approach is, in the context, very attractive of having patients being performed in an outpatient setting, because patient after procedure can immediately sit up, they can walk out of the cath lab, and they will be mobilized much faster. Hence, they can be discharged much earlier, which is very attractive if we go for an outpatient setting.
So if we take, for example, patients with chronic infections or high-risk infections, patients had a previous infection via a transvenous system, they're so high risk, the quality of life is improved by having a device with an infection rate of under 1 in 1,500 to 3,000. That on its own is an improved quality of life. Overall, we've not had anybody who's had a leadless system who's complained about their leadless system. Whereas that's not true of those that have a transvenous system. In those that are going to require ongoing pacing and they're on a journey for the rest of their life, then as a first step, we do use this as preserving vasculature, especially those, say, if they're in the 40s and 50s, and we know that there's going to be a pacing indication ongoing. It buys us time. And at some point, yes, they may or may not require a transvenous system, an upgrade, but over time, we've saved the vasculature. It's a revolutionary technology that has delivered in a huge way for patients, but also the clinical service. Before we implanted first in 2017, my vision already at that time was that there would be an entirely leadless system. That vision we're not quite there, but we're on the edge of this, and we're getting ever closer to it. And every single step forward, every evolution of each of the leadless systems on the market and coming to the market is driving us closer to that as a reality. The future is leadless in my mind, and at the moment there are caveats, so there are pros and cons with that. It's not a panacea for everybody at the moment, but we have to start somewhere. And by starting, we're 10 years into this journey already, over 10 years, and there aren't a lot of drawbacks to it. There are some, but that is what evolution's for, and that is what technology is, to try and improve the outcomes and the technology deliverance.